The Korean War is usually framed as a clash between industrial armies, each supported by modern logistics and medical systems. What is less discussed is how often those systems failed at the moment they were most needed. In mountainous terrain, under extreme cold, and during rapid movement, wounded soldiers were frequently cared for not by doctors, but by whoever happened to be nearby. In those moments, survival often depended on knowledge that did not come from military manuals at all. It came from households shaped by the Great Depression, where families had learned to manage injury, infection, and shock with almost nothing. If this kind of overlooked history is why you come to Echoes of Valor, take a moment to subscribe. This channel exists to examine how lived experience, not just doctrine, shapes survival in war. What resurfaced during Korea was a simple medic principle that Depression-era families understood instinctively: protect the wound, preserve the person, and do not intervene more than necessary. It was not sophisticated, but it was effective. The Great Depression quietly trained a generation in improvised care. The economic collapse of the 1930s forced millions of families to become their own first responders. Doctors were expensive or distant. Pharmacies were limited. Minor injuries, if mishandled, could become life-threatening. Families adapted by emphasizing cleanliness, restraint, and conservation of energy. Cuts were cleaned with boiled water. Cloth was reused but washed thoroughly. Wounds were covered and left undisturbed. Pain and swelling were managed by rest rather than intervention. These practices were not written as medical theory, but they were transmitted culturally. By the time World War II veterans returned home and later served as instructors, medics, or reservists in Korea, this mindset came with them. Korea exposed the limits of formal battlefield medicine. Despite advances made during World War II, the Korean War stretched medical systems thin. Helicopter evacuation existed, but weather and terrain often grounded it. Aid stations were mobile and frequently overwhelmed. Medics carried limited supplies. In this environment, attempts to perform ideal care often failed. Frequent redressing exposed wounds to cold and contamination. Overhandling increased shock. Families' Depression-era approach, do less but do it correctly, proved unexpectedly relevant. Medics who focused on stabilizing and protecting casualties rather than perfect treatment saw better outcomes, especially in delayed evacuation scenarios. The trick was not a technique but a priority order. First, stop what threatens life immediately. Second, prevent the body from losing heat and strength. Third, protect the injury from interference. This meant covering wounds securely, insulating the injured and, avoiding unnecessary inspection. Families had learned that constant checking did more harm than good. In Korea, this translated into fewer infections and less shock progression. This approach ran against the instinct to act constantly, but experience really reinforced its value. In both Depression households and Korean foxholes, ideal supplies were rare. Clean cloth, blankets, clothing, and shelter materials became medical tools. What mattered was not the material itself, but how it was used. Cloth was layered to insulate rather than compress. Pressure was applied gently but consistently. Movement was minimized. These actions preserved circulation and allowed the body to maintain equilibrium. The principle worked because it respected the body's limits instead of fighting them. Many Depression-era caregivers did not use the term shock, but they recognized its signs. Pale skin, weakness, confusion, and cold were understood as danger. The response was always the same: warmth, stillness, reassurance. In Korea, medics observed that wounded soldiers often deteriorated not from blood loss alone, but from exposure and exhaustion. Applying this old wisdom, keep them warm, keep them still, saved lives when supplies ran out. Later medical doctrine would formalize this understanding, but its roots were practical, not academic. After Korea, military medicine began to emphasize stabilization over intervention in the field. Combat lifesaver training shifted focus toward preventing deterioration rather than treating wounds definitively. The logic mirrored Depression-era care. Do what cannot wait. Avoid what can. preserve the body until higher care is available. The Depression-era medic trick matters because it shows how survival knowledge accumulates outside institutions. Families learned through necessity. War later validated those lessons under extreme conditions. It also reveals a recurring pattern in military history. When systems fail, survival depends on principles, not protocols. The simplest rules endure because they align with human physiology and limited resources. Understanding this helps explain why certain practices reappear across conflicts and generations. Modern medicine is powerful, but it still depends on timing, access, and environment. When those fail, older principles regain relevance. The Korean War did not invent these lessons. It reminded us of them. Remembering how Depression-era families cared for injuries and how that knowledge resurfaced in war adds depth to our understanding of endurance. It shows that survival is often preserved quietly, passed hand to hand, long before it is written into manuals. If you value this kind of grounded, historically honest analysis, subscribe to Echoes of Valor and share this video with others who care about understanding war beyond surface narratives. These lessons were learned in hardship, refined in war, and they remain worth remembering.